Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. Today, in continuity with the previous lecture series in neurology, today we'll be discussing on one of the very interesting topic, that is encephalitis, very commonly seen in younger children's and older person. So in these two age group, this is very common. And one of the most common cause of encephalitis is viral encephalitis. And among viral also, herpes simplex virus is the most common. We'll be discussing in detail as we go further. We'll be discussing under this common heading as routine, definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis and treatment part of it. Before we go into that, some terms which we commonly come across, that is meningitis is inflammation of meninges, and when there is an acute inflammatory process affecting the brain parenchyma, we call that as encephalitis. So the inflammation of brain we can divide into inflammation of meninges and inflammation of brain parenchyma. Meninges alone, meningitis; brain parenchyma, encephalitis. And when both are involved, it is called meningoencephalitis. So together, quite common, it can be there. And Encephalitis syndrome is an altered mental status where you got a reduced consciousness and altered behavior due to any pathophysiology which involves the brain parenchyma. That we call as encephalitis, encephalopathy syndrome. While acute inflammatory process which affects the brain parenchyma we call as encephalitis. So encephalitis is one of the cause for encephalopathy. So encephalitis is a inflammation of brain parenchyma, and the most common cause is virus, and among those virus, herpes simplex virus. In India we come across even Japanese encephalitis. In Western country, West Nile virus, Epstein-Barr virus, and there are many more viruses. Also, you can come across because of toxoplasmosis, some of the metabolic condition which can also produce encephalitis. And we do come across nowadays what is called as autoimmune encephalitis. It is very common in a young individual and also common in elderly individuals. The incidence is roughly we say from 3 to 7.5 per 1 lakh population. The risk factors wise, immunocompromised host, particularly HIV positive, AIDS, person with organ transplant because they are very frequently on a immunosuppression drugs, or if a person is on a immunosuppression drugs for any other pathophysiology, and any other cause of immunocompromise. Good number of times this is being transmitted by an infected virus or infective vectors we call mosquito, and even wild animals like bats, etc. And there will be symptoms and signs which will occur because of inflammation of brain parenchyma in the form of altered level of consciousness. Person can have seizures, headache, fever, cognitive function will be affected. All those findings will be there, very common. So encephalopathy is reduced or altered level of consciousness and maybe of any etiology, including even viral encephalitis. While when we say encephalitis, it is an inflammatory process, most commonly because of virus. Meningitis is inflammation of meninges. Myelitis is inflammation of spinal cord. Radiculitis is inflammation of nerve roots. And acute encephalitis syndrome is occurring at any age, at any time of the year. It is an acute onset of fever with altered mental status, that is confusion, disorientation, altered level of consciousness, and you will have effect on cognitive functions. There may be new onset of seizures, etc. That we call as encephalitis syndrome, acute encephalitis syndrome. And we have already told you most common cause is viral infection, or maybe because of indirect immune mediated mechanism, maybe there, where you can have a para-infectious etiology, or nowadays that is being labeled as autoimmune encephalitis. So that can be there. So this will be all broad spectrum. So encephalitis involves brain parenchyma, aseptic meningitis will involve meninges, myelitis involves spinal cord, neuritis will involve peripheral nerve. These are all the group of disorders which can be because of viral infection. Today we are going to discuss regarding only encephalitis. So suspected case, acute onset of fever, not more than 5 to 7 days duration, with altered mental status, with or without new onset of seizures, excluding febrile seizures, and in clinical finding, the person will be irritable or may have somnolence, abnormal behavior with usual febrile illness. So this particular we call as a suspected case. And also it is important that in an epidemic area, if the person is there with a fever with altered sensorium, then we do suspect person may be having encephalitis. And in India, very common, we have got Japanese encephalitis, which is quite common. And another common cause in India is cerebral malaria, particularly P. falciparum malaria, acute encephalitis syndrome. Another probable case means suspected case to be in an area where this particular disorders is quite common or there is an outbreak. And acute encephalitis syndrome may be because of other agents, maybe any other virus, and maybe due to unknown agent when there is no confirmation by diagnostic test. You cannot identify the etiology or we cannot identify the virus. Then we put them into unknown agents. Laboratory confirmed case means we confirm the diagnosis of the etiology by either identifying the presence of viral infection by IgM antibody in serum or in CSF, or increase in IgG antibody, or we isolate virus from brain tissue, or we detect antigen by immunofluorescent, or we detect a virus by PCR. Then we call laboratory confirmed case. So by and large it is detected by a presence of antibody or presence of antigen or presence of virus affecting cerebral parenchyma. There is one group where we call as autoimmune encephalitis, can occur at any age. This disorder is associated with presence of antibody against neuronal cells, and this can be severe and potentially fatal. And this is usually triggering factor is antibody production due to unknown etiology. And one of the common etiology can be a post-viral or maybe even in a paraneoplastic syndromes also. Acute demyelinating encephalopathy is an initial inflammatory demyelinating event with multifocal neurological deficit accompanied by encephalopathy. So it is acute demyelinating encephalomyelopathy. So encephalopathy is due to demyelination and it is acute inflammatory. The age group very commonly between 5 to 8 years, more common in male, and it is induced by infectious exposure or by vaccine, and that produces autoantigen, and this is one of the variety of what we call as autoimmune group of disorder. There is another variety we call as anti-NMDAR encephalitis, where antibody targets NMDA receptor, and because they involve that, it is an autoimmune encephalitis group, more common in female, and the age group is less than 12 years in 60% of the time. It produces autonomic dysfunction and usually mild to less severe variety. Few days of prodromal symptoms like headache, fever, viral symptoms, and then person can present as a psychiatric manifestation in the form of anxiety, agitations, delusions, then thought behaviors, bizarre behavior, labile factors, labile episodes, catatonic features, etc. Also may present as even insomnia and may have altered level of consciousness, dyskinesia, chorea athetosis, blood pressure fluctuation, hypoventilation, hypothermia, siluria. These are all basal ganglia and autonomic dysfunctions, and it is put as anti-NMDA receptor encephalitis. So viral and non-viral becomes the most common way of differentiation in an encephalitis. Another word, if along with brain parenchyma meninges involved, meningoencephalitis, and due to any other etiology along with encephalitis, we call that as encephalopathy. If idiopathic, we call primary. Very commonly primary is by and large acute in onset. Secondary, or commonly we use the word post-infectious, and one of that group is autoimmune. Occasionally we come across bacterial as a cause of encephalopathy or encephalitis. Fungal is also not common. Fungal parasites is not so common, but you can come across these groups in a immunocompromised host. Spirochetes is also not very common. Rickettsial is also not very common. The most common is viral. Metabolic is another common. Drugs, chemicals, and autoimmune can be other causes of encephalitis, or we can use the common word encephalopathy. So the common subgroups: infectious, most common cause will be viral. Another common is autoimmune. You can come across chronic encephalitis, limbic, HIV, encephalitis lethargica, which will end very frequently into Parkinsonism. Some of the autoimmune variety we call as acute disseminated encephalomyelitis is ADEM, and NDMA NMDA receptor associated encephalitis, that is N-methyl D-aspartate receptor associated encephalitis. Once in a while associated with Hashimoto's thyroid disorders, we call thyroid or thyrotoxic encephalopathy, but best labeling is Hashimoto's encephalopathy. And there is one another odd variety called as a Rasmussen encephalitis. These are part and parcel of autoimmune. Sorry. If we go through the etiology, the most common cause is viral encephalitis. Not very common is acute pyogenic, but it will produce more of meningitis rather than encephalitis. But together we put them into an acute encephalitis syndrome. Tubercular meningitis will be another group, but not very common. But it is common in India. But it will be more of meningitis rather than encephalitis. Cerebral malaria is a very common, it will produce encephalitis, or we can call them as encephalopathy. And we have already mentioned acute disseminated encephalomyelitis, which will be belonging to autoimmune group of disorders. So causes we can divide into viral, non-viral, para-infectious group and other viral groups. Among virus, the most common will be mumps, measles, rubella, hepatitis serpec, herpes simplex virus. This comes topmost on the list. Enterovirus, arbovirus, influenza, adenovirus, rabies, etc. These are some of the common. Of that, herpes simplex comes topmost on the list. Another common, Japanese encephalitis, rabies will be quite common. Mumps, measles and rubella can also produce encephalitis, very common in children. As far as non-infectious group is concerned, rickettsia, mycoplasma, some of the bacterial infections, spirochete, protozoal, fungi, cat scratch disease, etc. Among other virus, particularly HIV, Kuru, this is Jacob disorders, subacute sclerosing panencephalitis groups, or progressive multifocal leukoencephalopathy, they all belong to other group of viruses. As far as a para-infectious group is concerned, post-infectious very commonly along with viral infections, allergic, autoimmune, we have already mentioned two common words in autoimmune, post-vaccination, paraneoplastic, Rey syndromes, certain toxins, and one we should not forget, when we cannot identify the cause, we usually label that as idiopathic. Among the virus we have already mentioned, the most common is herpes simplex virus, which is accounting for, viral infection is accounting for almost 70% of encephalitis group. In Western country, West Nile virus, some of the mosquito-borne virus like dengue, equine virus, St. Louis virus, Japanese encephalitis, Zika virus, etc., which are mosquito-borne viruses. Less common virus will be polio, Epstein-Barr, cytomegalo, mumps, rubella, rabies, herpes zoster, etc. Occasionally toxoplasmosis, aspergillosis. This will be more common with immunocompromised host. Then metabolic encephalopathy will be another big group. Occasionally you can come across T-cell lymphomas producing infiltration and can produce encephalitis or encephalopathy. And we have already mentioned anti-NMDA receptor encephalitis, which is called brain on fire. And this is again one of the variety of autoimmune groups. So we already mentioned infectious group, viral and non-viral. Non-viral can be bacterial, parasitic, fungal and rickettsial. This will be more common with an immunocompromised host. And among non-infectious group like post-infections, demyelinating process, autoimmune, drugs, chemicals, metabolic, hypoxic, nutritional disorders, etc. But they will be more like encephalopathy group. They will be more common in that encephalopathy group. Among mumps, you can see these are enterovirus. This is herpes simplex virus. The fatal variety is more common with herpes simplex, while meningitis is more common with enterovirus like mumps. So this will be the way the pattern will be seen. So in herpes simplex we get more of encephalitis, while with mumps we get more of meningitis presentation. This is a big list of bacterial infection. These are rickettsial different infection. These are fungal. These are parasitic. In India, cerebral malaria, particularly P. falciparum, is quite common. But good number of time, rickettsial infection, fungal infections, other parasitic infections, they are more common with immunocompromised host. Even among these bacterial infections, some of the bacterial infections are common again with immunocompromised host. Among non-infectious group, we already mentioned one of the group which is autoimmune disease, acute disseminated encephalomyelitis, short form we call as ADEM. Then antibody associated encephalitis, post-vaccination, hyperpyrexia, heat strokes, Rey syndromes, certain plant toxins. These are quite common. Hypoxic encephalopathy, traumatic encephalopathy, vasculitis, etc. can be seen. And this will produce non-infectious encephalitis. So electrolyte imbalance can also produce chemicals, toxins, carbon monoxide, organophosphorus poisoning. Then we call as charas, ganja, bhang, lead, paraneoplastic, metabolic like hepatic, uremic, etc. But these are usually put into non-infectious group, but we put them into encephalopathic groups, acute encephalopathic groups. So they can be common in younger children and elderly individuals, particularly with immunocompromised or person who are on immunosuppressive drugs, etc. and person who are living in endemic areas. It is quite common. So encephalopathy we already mentioned, hypoxic, ischemic, metabolic, toxic, vascular, non-convulsive status, nutritional deficiency, cerebral malaria, that is particularly P. falciparum, even in case of enteric fever, traumatic brain injury, malignant hypertension can produce Rey syndromes, Hashimoto's encephalopathy, paraneoplastic and neuroleptic malignant syndrome, etc. There will be a very big group in case of a encephalopathy. Autoimmune variety, we already mentioned, limbic encephalitis. There are many other Hashimoto's, basal ganglia, limbic variety, that groups. Among pathophysiology, virus enters via vector bites or via droplets. It enters the body via upper respiratory passage. It will produce viremia, and after producing viremia, it will enter into CSF and will produce local inflammation and may involve meninges, then we call as a meningoencephalitis. And when the person gets brain parenchyma involved, there will be altered level of consciousness, new onset of seizures, person can be drowsy, irritable, altered behavior, right from drowsy till stupor and coma, and person may also develop neurological symptoms and signs. And because of involvement of the meninges along with encephalitis, then we call that as a meningoencephalitis. Then person can have even meningeal signs. So that will be the peculiar involvement in case of a viral encephalitis. So main spread is by hematological spread. Once virus enters into the bloodstream, they will be spread to the neurons, and most common virus will be herpes simplex, herpes zoster, rabies virus, and from there you can have a retrograde transmission involving the brain parenchyma. And now once the virus invades the brain parenchyma, there will be a host inflammatory response, and you will have a damage to neurons in the form of maybe demyelination or maybe a neuronal degeneration. These are all the different viruses which are there, how they are spread, maybe fecal-oral route, or by a mosquito, or by a tick-borne, or a airborne, or by a human contact, which season, etc. At your leisure time you can go through. And this will be the which season of the year you will have a peak season. Say enterovirus peak season will be in July, August. Herpes also will be in July, August. Mosquito borne here. Mosquito borne will be from May to October. Mosquito borne. Sorry, it will be June to October. While enterovirus from May to November. Tick-borne will be entirely all throughout, but maximum between May to December. Mumps will be all throughout the year. These are the seasonal variation. And these are multiple other viruses which are being mentioned here. That is enterovirus, secondary viremia stage, primary viremia, how it spreads, what are the different viruses, which part is being involved. Polio and Coxsackie virus will involve BRAIN.MOST producing encephalitis, while other virus will produce involvement of the other organs also simultaneously. And very frequently person gets transmitted by a mosquito or other, and it is from animal. Infected mosquito will now transmit to the human beings. So it is called animal arthropod men's cycle. So mosquito bite will transmit that particular virus, like Japanese encephalitis virus, which will multiply, then neuron involvement, enter central nervous system, they will replicate, they'll destroy those particular neurons and will produce the changes in the gray matter, and then person will start developing symptoms and signs. Mainly thalamus, basal ganglia, brainstem, cerebellum, hippocampus, cerebral cortex, etc. may be involved, and good number of time it is fatal. So that is peculiarity of a Japanese encephalitis cycle. This is indirectly how you get the production of IgG and IgM. This is IgM will be produced within 90 days of illness, and then IgG will persist. Fever will be there for few days, then person will have a CNS disease, and after approximately 3 to 4 weeks, person will start in a recovery phase. In general, clinical features will be of a viral infections like high-grade fever, severe body ache, arthralgia, arthritis, myalgia. And once there is an involvement of the cerebral hemisphere, person can have altered level of consciousness, altered mental status, and secondary seizures. We usually call new onset of seizures. And depending upon the area, what is being involved, neurological symptoms and signs. If meninges are irritated, person can have even neck rigidity or neck stiffness, Kernig signs and Brudzinski signs may be positive. Person will also have a slight elevation of intracranial pressure in the form of headache, vomiting, and person may have visual disturbances. Because this virus can also involve other organs like lung, heart, peripheral nerves. So person can also present with associated other findings. And good number of time you can see we call sore lips, and you can have even a rash over the body. So rash will be very common. You can have a sore lip, or we call herpes labialis. You can have even ananthema, that is oral ulcers. So initially acute flu-like symptoms like high-grade fever, severe headache, altered level of consciousness right from lethargy, drowsiness, altered mental status to a coma, seizures, and focal neurological symptoms and signs. May also come to you with aphasia or dysphagia, behavior disturbances may be also present. So common symptoms like fever, headache, lethargy, poor appetite, hyperesthesia, drowsiness. 2. Signs like ataxia, confusion, irritability, stiff neck, and you might have neck rigidity, vomiting, photophobia, phonophobia may be also seen. So almost we have mentioned majority of the symptoms and signs. So all those signs may be present. So prodrome signs like severe headache, myalgia, malaise, so fever, altered mental status, new onset of seizures, altered level of consciousness right up to coma, and focal neurological signs will be very, very common. So headache will be usually severe, different from normal headache, and person might have vomiting along with this headache because of raised intracranial pressure. Muscle pain is also quite common, malaise is quite common. Fever, usually high grade fever, altered mental status, which can be right from few hours to days. Cognitive disturbances in the form of hallucination, disorientation, cognitive function will be affected, behavior changes, memory deficit can be seen, person can have seizures, altered level of consciousness will be quite common. Focal neurological deficit is also seen. And other findings, you can see vesicles in herpes simplex over the skin, usually we call herpes labialis. Lymphadenopathy may be present, splenomegaly will be seen, and particularly in case of encephalitis lethargica, you can have even Parkinson features because of the damage to basal ganglia. Stiff neck, quite common, along with irritation of meninges. Brudzinski sign, Kernig sign may be seen. Nausea, vomiting because of raised intracranial pressure, photophobia, phonophobia is also quite common in encephalitis. Now some of the associated symptoms which will be there we call cold sores or herpes labialis, very commonly seen, and person may have a memory disturbances, aphasia, lymphadenopathy, and splenomegaly is very common with Epstein-Barr virus. Parkinson features will be very common with Japanese encephalitis, and you can have asymmetrical lower limb paralysis more common with Japanese encephalitis. Then EV71 virus encephalitis will produce pulmonary edema, tremors, and myoclonus, while anti-NMDA receptor encephalitis will usually be associated with paraneoplastic, very commonly ovarian teratomas. So this may be associated symptoms. So altered level of consciousness, altered mental status, altered behavior, focal seizures or generalized seizures, and focal neurological signs are the classical signs. So this will be all big list of groups of symptoms and signs. We have already mentioned majority of them. So aphasia, ataxia, hemiparesis, involuntary movement, cranial nerve palsy, etc. can be seen along with encephalitis. More common in newborns and infants, where you will have a body stiffness, irritability, poor feeding, bulging fontanelles, vomiting, etc. So sudden fever, headache, vomiting, diarrhea, lethargy, irritability, tremors and convulsions, changes in altered level of consciousness, etc. Diagnosis is always first by suspicion, that is clinical diagnosis, which becomes of prime importance, and then you have to demonstrate the presence of virus either by CSF examination or neuroimagination or by PCR. So in a CSF you will demonstrate normal glucose, slight elevation of protein and lymphocytosis. And in CSF you can demonstrate presence of virus by PCR. CT scan will show you the damaged area, CT or MRI. And particularly low density lesions in temporal lobe will be more indicative of herpes simplex virus encephalitis. And you will have an increased opening pressure while you do a lumbar puncture. EEG may be of some help in case of a Japanese encephalitis because it shows a typical EEG pattern. So always suspect, investigate properly, you will be able to come to the nearmost diagnosis. So this is a big list of history taking. We have already mentioned majority of them, but these are all the big list of questions which you will be asking in a person if you want to rule out encephalitis from other pathophysiology which produces similar symptoms and signs. So clue mainly you go from the history. Very commonly you get the presence of races, recent history of vaccination, travel history to an endemic area, or animal bite, insect bite, or very commonly mosquito bites. And if the person is an immunocompromised or is on immunosuppression drugs, or person is having diabetes mellitus, chronic alcoholic, and if he is on steroids, etc., that will produce immunosuppressions. So skin rash, insect bite, vaccination, etc. Very useful clue for confirming viral encephalitis. CSF examination, we have already told you, usually glucose will be normal. CSF cell count will be not much elevated, mainly lymphocytes. Protein will be slightly elevated. Gram stain will be negative. Occasionally, if it is a bacterial, then only we will be able to demonstrate by gram stain or by Jaden stain in tubercular meningitis. But for viral, PCR will be very useful and it will be diagnostic. Difference between encephalitis and viral meningitis: fever will be common in both. Raised intracranial pressure will be common in both. Photophobia will be more with meningitis rather than encephalitis. Meningeal signs will be also more common with viral meningitis, which will be producing neck stiffness, Bruzgitki, and Kernig sign positive. Neurological symptoms and signs will be much more with encephalitis rather than pure viral meningitis. Seizures will be also more common with encephalitis rather than meningitis. Cranial nerve palsy will be also more common with encephalitis rather than pure viral meningitis. And altered mental status will be also more common with encephalitis rather than meningitis. Indirectly, meningitis will signs will be present more in viral meningitis, while brain involvement will be more common with viral encephalitis. Now, to differentiate encephalopathy from encephalitis is also very important, because in encephalitis fever is more common, headache is more common, altered mental status is also more common, and it will be fluctuating. While in case of encephalopathy, altered mental status will be nearly same. Focal neurological signs will be more common with encephalitis, while in case of encephalopathy, you will have a generalized signs in the form of generalized seizures, while in encephalitis more common will be focal seizures and you might have a generalized seizures. Focal neurological signs in encephalopathy is less common, it is usually generalized, while in case of encephalitis it is usually focal neurological signs. Laboratory wise, we have already told you that in encephalitis you will have a leukocytosis, pleocytosis, and EEG will be abnormal, while in encephalopathy it will be generalized diffuse slowness, and MRI will be good number of time normal in case of encephalopathy, while in case of encephalitis MRI will be diagnostic showing you a focal damage. This I am skipping over. This is an autoimmune variety and this is infectious encephalitis. At your leisure time you can go through. Now this is what is called a step 1 rapid assessment. We have already mentioned majority of them. Then clinical evaluation, and then we go to the investigation. Mainly in investigation CSF and MRI comes topmost on the list. You have to demonstrate the organisms and you have to demonstrate the damage to cerebral hemisphere. So rapid assessment, first stabilize the patient, clinical evaluation, that is including history and examination, then followed by investigation should be done. And then on empiric grounds, depending upon the etiology you suspect, either antibiotics, antiviral drugs, supportive care and prevention. That is very, very important. And in a recovery stage, physiotherapy and other. So that should be done. Post-encephalitis presentation is quite common, and person can have lot number of different symptoms and signs like personality changes, physical disturbances in the form of difficulties, memory problems, then problem with pain and other sensations, probability with daily activities, fatigue, headache, then cognitive functions, learning, convulsions may be present, person may get what we call as epilepsy, and person might have poor selected skill, behavior disturbances, etc. So right from all this, personality changes, physical difficulty, memory problem, emotional problems, skills, then fatigue, hormonal problem, cognitive problems, new learning, then epilepsy, inappropriate behavior, etc. can be after encephalitis. So this will be indirectly post-encephalitis complications. And this is in nutshell, a person who comes to you with a headache, fever and slight neck rigidity with altered mental status, how you approach. If a person has got altered mental status, answer is no, then do rule out meningitis. And if there is an altered mental status, you always suspect meningoencephalitis, encephalopathy, SOL, or autoimmune groups. And then you proceed further by blood culture, CT scan, and then proceed further. So main investigation is lumbar puncture, that is CSF examination for antibody and for presence of virus by PCR test, and MRI will be very useful. So virus isolation, you can do it from CSF, nasopharynx, stool or urine, and that you can do by PCR, radioimmunoassay or ELISA technique, or even by nucleic acid probe, or you can detect antibody like IgM followed by IgG. So CSF examination gives you an indirect clue where the sugar will be normal, elevation of protein, slight elevation of protein, and mainly pleocytosis in the form of more of lymphocytosis. And you can also isolate virus from serum or from CSF or from oral cavity, stool or urine will be very useful for confirming the diagnosis. So CSF can be sent for PCR to find out which virus, whether herpes simplex, cytomegalo, Epstein-Barr virus or varicella virus, etc. You can subject to RT-PCR test. CSF finding difference between bacterial, viral and tubercular. I've already discussed. I'm keeping this slide for a short time. You can go through your lizard. I've already discussed in CSF examination. This is again same I've discussed in CSF examination. At your leisure time, you can go through this and you can go through this slide also. This is another slide showing you difference between bacterial, viral, fungal, tubercular and other. So after confirming the diagnosis, this is MRI which shows you involvement of the brain parenchyma. I am not expert as far as MRI is concerned. You have to differentiate this from encephalopathy, which can be because of bacterial, traumatic, toxic, hypoglycemic and other condition which mimics identical like encephalitis. Management will be first symptomatic, supportive care, maintain the vital data, and as the most common cause is viral, antiviral drugs, it is in very few viral infection, antiviral drugs is useful. By and large, empiric treatment is started. Antibiotic if you are suspecting bacterial infections. Most commonly we use antiviral drugs, particularly acyclovir. Steroid is very useful to prevent a subsequent complications because of acute inflammation. And you have to treat raised intracranial pressure, cerebral edema and seizures, and even some of the complications during acute viral encephalopathy like hypothermia and other complications. You have to prevent for preventive purpose in an epidemic area. Vaccination, isolation and vector control will be very helpful. So most commonly there is no specific treatment available, but in case of a herpes simplex virus, acyclovir is effective. Varicella zoster virus also acyclovir is effective. In cytomegalovirus there are other antiviral drug, that is gengiclovir is effective. In immunocompromised host, steroid will be very helpful. And while treating raised intracranial pressure, mannitol, steroids and other measures will be useful. And supportive care is utmost important. This is all the different other etiology like hypoglycemia, intoxication, as well as other conditions which can produce differential diagnosis, and you have to take care. So always keep it in mind, rule out other conditions simultaneously. So rapid assessment, clinical evaluation, followed by investigations, empirical treatment, and after confirming the diagnosis, specific treatment. Along with this, supportive care is absolutely must, and prevention. And then once the person recovers, rehabilitations and treatment of complications. And as far as prevention is concerned, we have already mentioned vaccination, isolation, and care for vector. All these are absolutely necessary. These are all the different algorithms they go for other etiology. So depending upon what you care, so ICU care, ICP monitoring, fluid restriction, avoid hypotonic solutions, anticonvulsants, then prevention of aspiration, physiotherapy, prevention of DVT, etc. Because person will be invariably unconscious. So all those supportive treatment, acyclovir, antibiotics, management of complications. So almost remains same. Control of seizures, prevention of complications, supportive care. These are all supportive care. So symptomatic antiviral drugs for prevention, vaccination in epidemic areas. Then acyclovir, antibiotics, anti-malarial if you are suspecting cerebral malaria, etc. So I can skip over all this. Management of convulsions. Then once a person recovers, you can go for all what we call as physiotherapy, acupuncture, massage, exercise, all those can be done. And for prevention, we have told you vector control, isolation, and vaccinations will be very, very helpful. And vaccinations are available for polio, H influenza, rabies, MMR, Japanese encephalitis, and you can take the advantage of even immunoglobulins can be utilized. As far as complication is concerned, early complications, seizures, coma, cranial palsy, and motor weakness. Among chronic complications, secondary seizures, SIDH, raised intracranial pressure, coma, encephalitis lethargica, Parkinsonism can happen as a chronic complications. So acute complications, seizures, SIDH, raised intracranial pressure, respiratory arrest, coma, and death. Chronic altered behavior like depression, personality changes, neurological symptoms and signs like gait disturbances, memory, speech, visual, mental retardation, hemiplegia, seizures, encephalitis lethargica, Parkinsonism, etc. can be a common. So in general, DIC, dehydration, respiratory arrest, death, vasomotor collapse, cerebral malaria, cerebral edema, coma, respiratory complications, and seizures. This will be in acute complications. This is little regarding a Japanese encephalitis, which is very common in India, very commonly in Uttar Pradesh, etc. Quite common. It is a flavivirus, first discovered in Japan in 1935, and it leads to encephalitis. Less than 1% of the patient has got neuroinvasive disease. It is the number one cause of viral encephalitis in Asia, and it is more common in children. And WHO estimates that there are 6 8,000 new cases of Japanese encephalitis each year. Probably it may be more than even this figure. Transmission is mainly by a pig to birds, pig and birds, this particularly, and the vector is mosquito. And humors are the end hosts. And the mosquito is a Culex mosquito, and that is Culex visnui, and it is very common in a rice field areas. So the mosquito bite is usually in the evening or overnight hours. So it is quite common in those areas. And it will involve basal ganglia, thalamus, pons, and brainstem, particularly midbrain. Those structures are more commonly involved. Incubation period is 5 to 15 years. Right from asymptomatic person can get seizures and can even succumb. Initially fever is very common, GI symptoms are quite common, and later on the person starts developing neurological symptoms and signs. The common symptoms: fever, headache, nausea, vomiting, diarrhea is very common, generalized weakness. And once the person gets involvement with the brain, then person will have seizures, altered behavior, tonic and clonic convulsions, focal neurological symptoms and signs, etc. Person can develop because of damage to basal ganglia, Parkinsonian features in the form of tremors, asymmetrical limb paralysis, and person can also present as an inappropriate secretion of ADH in the form of hyponatremia. Diagnosis is always by confirmation of IgM antibody against Japanese encephalitis virus. MRI will show you a brain lesions. Main treatment is supportive treatment. There is no specific antiviral drug which is available. What you require is isolation and care for vector, that is mosquito vector care is absolutely there. Now Japanese encephalitis vaccine is also available, so vaccination should be done in an epidemic area or endemic area. Complications very commonly occurs in almost fatal complications in 20 to 30% of the group of children, and after recovery person will have very commonly upper or lower motor neuron weakness, cognitive impairment, speech impairment, recurrent seizures or we call secondary seizures, and behavior problems. Good number of time this particular person can also present as Parkinsonism. So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable and I appreciate that you have spent some of the time with me. This topic can be asked to you in your theory as a full question, can be asked in your oral. More important, you will see some of the time this group of people in your everyday practice, more commonly seen in children and also in old individual who will present with an altered level of consciousness after ruling out the metabolic causes. You must keep it in mind what we call as encephalitis, and if the person presents with fever, altered level of consciousness, seizures, symptom signs of raised intracranial pressure, focal neurological symptoms and signs, do not forget to ask for MRI and CSF to rule out viral encephalitis. If you like this particular lecture, don't forget to press button like, subscribe, press bell icon, and if you feel it is helpful to your friend, do share with your friends also. See you in next lecture.